Hi, this is a case of bilateral TAPP for a post-TEP left-sided inguinal hernia and a primary right-sided inguinal hernia. So we start with the first ports well away from the umbilicus, above the umbilicus, to give us enough space to reach the peritoneal flaps. So laparoscopy reveals adhesions on the left side. So we're just checking to see how bad the adhesions are. So this is the initial part of the diagnostic laparoscopy, and you can see that the mesh is visible. It's a bar 3D Max mesh, and you can see that there is an inferior and lateral recurrence. So obviously during the primary procedure, the peritoneal flap sneaked in under the lower edge of the mesh. Now on the primary right side, we are raising the peritoneal flap high up. So we want a larger peritoneal flap so that the mesh can be covered fully on both sides. So we started off higher. My dissecting instrument of choice is a sealing device like the Thunderbeat or LigaSure or harmonic scalpel. You can see the Thunderbeat being used here. And since we reuse these instruments, cost is not a factor here. So you can see that after the peritoneal incision, we are dissecting off the fibers and dividing them as we move downwards. So as we move downwards, we reach the area of the internal ring, and you can see that there is a lipoma which is visible, and we just dissect that lipoma off, taking care not to leave any of the fat distally. There. Now we extend the peritoneal flap medially towards the medial umbilical ligament, which is our initial medial extent of the incision. And we complete raising the peritoneal flap on this part, the medial part, and we expect that the midline will be more difficult. You can see the inferior epigastric vessels here, and they need to stay towards the ceiling. So that would be the right plane. So push the inferior epigastric vessels towards the upper part and stay beneath it. So you can see on the left side of your screen the midline adhesions. So we're not disturbing them. What we aim to do at this point is to dissect inferiorly till we can reach the cave of Retzius and the pubic bone ligament of Cooper. So the dissection continues steadily, and we use a gauze piece to dab the blood and do some bit of blunt dissection. And you can see now the cave of Retzius and the ligament of Cooper, the shiny white structure there. And now we are now going to dissect the cord structures and the sac. So you can see that dissection right now. The sac is now being held with the left hand and teased off from the cord structures. So the proximal end of the sac is ligated with vicryl, and the distal end is transected using the Thunderbeat, taking care not to seal the distal end of the sac, leaving a potential hydrocele. Now on the left recurrent side, we happily see that the mesh is well in place and there is an inferior recurrence through the indirect opening. So we do not disturb the peritoneum on top of the mesh. So we incise the peritoneal flap below the lower edge of the mesh and dissect the MPO from below. So you can see that process there. Now if you see now, the peritoneal flap has to go down vertically because we started off high up, but on the left side we did not disturb the peritoneum over the mesh, so that peritoneal flap is low, so we are going down vertically and connecting the two peritoneal flaps. So the dissection on the right side continues, and all the structures are demonstrated. You can see the inferior epigastric at the top of the screen, right in the center. And we place in an extra large light 3D Max barred mesh, that's on the left, and we're just checking that the peritoneal flap is large enough to cover it completely. So a couple of tack fixations to the mesh leaves us with the freedom to suture the peritoneal flaps and close this space. Otherwise, these meshes could keep falling on top of the instruments. Otherwise, normally these do not need fixation or require minimal fixation. So using a 3O V-lock suture, we are starting the peritoneal flap closure from the medial side and covering the left side first. So it's important to have a large flap so that no part of your mesh is exposed to the intestines. So you can see at the lower part there is some more of the mesh which is exposed, and now this is the right side of the patient where we are closing the defect. So this is the complete procedure. At the end of it, there's still a little more of that peritoneal closure being shown on the left side of the patient, which is where the colon was trying to sneak in through a gap. And that was the procedure, and the patient did very well. Thank you very much.